So at the outset, I'd like to thank the Tirupur IMA for giving me this opportunity, and the office bearers, especially Dr. Devarajan, for giving me the opportunity to talk on this an important topic which we commonly see. Okay, so coming to fever cases, only around 50 to 60% of the patients can be diagnosed on ultrasound. So not all cases can be diagnosed the source of fever, and among this, in 10 to 12% of the cases, ultrasound can detect an unexpected source of fever. So you may think fever is because of something else, and when you do a scan, that will be a liver abscess, something like that. You will come up with which you see. Among this 50 to 60%, the majority is in the abdomen. 50% is in the abdomen, and next comes to the chest, lung, and heart, 26%. Then the head and neck region, 12%, and extremities is 4.5%. So moving on to head and neck. So here is an example where there is a normal lymph node. Normal lymph node will have a well-defined oval shape with central bright sinus echo, and on color there will be a flow to the sinus echo. This is a very normal looking lymph node. And here you see an abnormal lymph node, which is enlarged in size. You can get sometimes oval shaped or round shaped. This is a well-defined round shaped, oval shaped lymph node, and you will see absence of the central sinus echo. This is a bright central sinus echo, which is totally absent here. So this is an abnormal lymph node. So another criteria is like lymph node size, like, you measure the short axis. If short axis is more than 10 millimeter, then we think it's an abnormal lymph node. So the differential diagnosis, you can think of lymphoma. Commonly we see tuberculosis. Then rarely we can see some disease like Kikuchi's, Kumura's disease, like that. Those things are very rare. And here is an example where you see a matted lymph node and there is some amount of necrosis. If you see this necrosis or caseation and this matting of lymph nodes, then you can think of tuberculosis, which is very common here. So this is another case of fever where you see a swelling in the parotid region, and on the left side you see a normal parotid gland. The normal parotid gland is very homogeneous in appearance and appears hyperechoic and homogeneous. Whereas you see on the right side, there is a lot of small black dots like hypoechoic, small hypoechoic areas. So these are very classical of acute parotitis. So acute parotitis, you can have either bacterial or viral parotitis. So there is another case where you have a swelling in the parotid region, and an ultrasound shows an abscess. So abscess, you see that irregularity and cystic areas with internal echoes. If you see a picture like this, it is most like an abscess. So right parotid abscess. So a case where again swelling in the cheek region, and ultrasound showed an irregular abscess here. That abscess, the root cause is root canal infection, and which has spread to the cheek, and an abscess below the masseter muscle. I hear a lot of disturbance. Is it? It's from my side, or is it okay? Hello.
No, sir. It's from someone else.
Okay. Okay. No problem.
Unmute.
And
better all others, please unmute yourself. Only speakers can.
Yes, sir. I will do, sir. I will do from host, sir.
எல்லா கிளாஸ் விட்டுட்டு சரியான எல்லா கிளாஸையும் விட்டுட்டாங்க.
Yeah. So this is another case where you have a swelling in the submandibular region, and ultrasound shows a calculi in the submandibular duct. Around the calculi, you see the dilated duct, and you also see a collection here. You can see a collection with the internal echoes, and this was an abscess. And you can see the enlarged submandibular gland. Again, submandibular gland will appear homogeneous in appearance in a normal gland. When it's infected, you can get an enlarged gland, and with the dilated duct, you can see a dilated duct, and gland is enlarged and appears slightly heterogeneous in echo texture. And you see a calculus. Because of this calculus, there's secondary infection and abscess. So again, causing fever in this patient. So when you see a fever or enlarged lymph nodes, we can put a needle under the ultrasound guidance. So here you can see you get the pointer. So you can see the needle passing here, and you can aspirate the abscess and send for a culture and for further to get the final diagnosis. Sometimes you have whether it could be bacterial abscess, could be tuberculosis, or it could be lymphoma. So all these conditions, you can put in a needle and get a diagnosis. So these are the common causes of fever in neck. So moving on to the chest. Chest is one area where ultrasound plays a very minor role. So here you see the normal. When you put a probe in the chest, you will see the chest wall, and you'll see the pleura here. Beyond the pleura, the lung contains air. Air is a very bad conductor for ultrasound. So all the ultrasound will be reflected back, and you will not see the lung at all. So this is the normal appearance. All these are reverberation artifacts caused by the air within the lung. So in case of infection or pneumonia, what happens is the lung is filled with fluid or exudate. So, and within that exudate, that bronchi, terminal bronchi will have air. So you will get this typical, this air containing bronchiole appearing bright with artifacts. Because of this air within the bronchi, there is a reverberation artifact, and the fluid filled lung appears as black. And this is a chest wall. So you can appreciate the consolidation. So in case of the consolidation, central consolidation will be difficult to appreciate. The consolidation should be close to the chest wall. If it's close to the chest wall, then we'll be able to appreciate the lung consolidation as a hypoechoic area with air bronchogram, which is appearing as a bright structure. So the next thing is fluid. Fluid is a very good conductor of ultrasound. So when there is pleural effusion, even a very minimal pleural effusion, less than 20 ml, you can appreciate in ultrasound, whereas in X-ray chest, you will not be able to see the pleural effusions. So small quantity of pleural effusion will be seen in ultrasound. Here, this is the spleen, this is the diaphragmatic surface, and you can see the black fluid, which appears fluid. Fluid always transmits the sounds very well. So there is no reflecting sound, so that's why it appears very black here. So these are again the same left pleural effusion. You can see it very well. This is a spleen, this is a kidney. So the two things which can be appreciated on chest is one is the consolidation and there's a pleural effusion. The third thing is the cardiac. Like sometimes you get infection in like endocarditis. So you do an echo, you can pick up the vegetations in the mitral valve. So that also is one of the cause for the fever. So here another example is a loculated collection. It's a loculated collection in the pleural cavity, and you can see a lot of internal echoes inside. So this was an empyema. So which was present fever in this patient, and this is the liver. So moving on to the breast. This is a normal breast, which you see this pattern like echogenic hypo like this. This is a very normal pattern of the breast. Whereas this side you can see a large abscess. So abscess will appear hypoechoic with a lot of small internal echoes. And when you press the ultrasound probe, it will move. This is very classical of breast abscess. This is again another case where there was an axillary swelling. Again, this is an abscess in the axilla. You can see an irregular wall. You can see a lot of internal echoes. And when you press with the ultrasound probe, this internal echoes will keep moving. So this is a classical axillary abscess. So next, we will move on to the abdomen and pelvis, which is the most common focus for fever. And here is an example where this patient was suspect of a dengue fever. So whenever you suspect dengue fever and when the platelet count keeps coming down, when it comes below like 40,000 or 50,000, then you will see in ultrasound the classical findings of gallbladder wall thickening. You can see this gallbladder wall is thickened. This is the wall which is thickened, and you can see a little bit of fluid around it. So this is the edematous gallbladder with wall thickening, and you can see a little bit of fluid effusion. You can see a nice fluid effusion here. This is the liver, and this is the fluid effusion. So this is quite a common finding you see in dengue fever. So, but sometimes the dengue fever ultrasound will be totally normal when the count is not that much less. When the count is close to 1 lakh, those cases you will not get this finding. But when count comes down, you do see this finding. Apart from this, you can have hepatomegaly, ascites, splenomegaly. All these things can happen in dengue fever. So whenever you have a patient with fever, then jaundice, you do an ultrasound, you will see again the GB is contracted, GB wall is thickened and edematous. You can see the pericholecystic fluid here, and the liver appears dark here. Actually, the liver will be slightly more echogenic than this. Here, the liver appears dark. Why I'm saying the liver is dark? Because of this biliary, the portal radicals, the portal vein branches, they appear, the wall of the portal vein branches appear very bright. So they appear very bright in the background of a dark liver. This is starry sky appearance. So many times you don't see the starry sky appearance, but especially when you see in children in hepatitis, you see these conditions quite often in ultrasound, the starry sky appearance. In adults, you don't see that, but you often see this GB wall thickening, contracted GB, edematous and pericholecystic fluid. All these things you get in viral hepatitis. Or in case not only viral hepatitis because of hepatitis B virus or A virus, also in other viral infections also you do see these findings often. So here is a case of a liver abscess, and patient was presenting with the fever, and on ultrasound shows a well-defined wall with anechoic or hypoechoic area with a lot of internal echoes. This is very classical of liver abscess. You can drain this liver abscess using ultrasound guidance. This is another case where the spleen, there's a splenic abscess. You can see the splenic abscess, again the cause of fever. So moving on to the retroperitoneal region, you see a lot of enlarged lymph nodes in this hypoechoic areas. This is the aorta, and this is the pancreas, and this is splenic vein. So you see a lot of lymph nodes, enlarged lymph nodes here. And again, in this view, you see kidney and liver, and here again you see a lot of lymph nodes. This is IVC going up there. So when you see large lymph nodes, the possibility with fever that you think of, it could be a tuberculosis or it could be a lymphoma. So this case on biopsy proved to be a lymphoma. Another case, patient presenting with fever on ultrasound, you see a little brighter kidney, and corticomedullary differentiation is lost. Actually, cortex will be little brighter, and the medullary pyramids will be little darker, blackish in appearance. Here you can see this slightly black and this slightly brighter, whereas here it's totally obliterated and slightly bright in echoes. And you can see the ureter here, and the ureteric wall is also thickened. The ureteric wall was thickened, and this patient had a pyelonephritis with ureteritis. So here was a case, and this case actually in outside ultrasound, they reported as multiple calculi in the kidney. So all these things, this echogenic bright shadow, they thought as calculi. Actually, patient was a diabetic and he had a severe fever. And when we did the ultrasound, it's better always do ultrasound in change the position of the patient to decubitus, supine. So if you change the position, this apart from this calculi, this was moving with the change of position of the patients. So air usually moves to non-dependent position when you change the position of the patient. Because it was moving and it was producing a reverberation artifact, rather than the stones usually produce a black artifact, post-acoustic blackness will be there. You will get a black shadow. whereas in air it will be a reverberation artifact. And you can also appreciate that when you keep changing the position of the patient and scanning. So this was a classical emphysematous pyelonephritis. And you can also see the air continuing in the ureter in this patient. So all this was fitting into the emphysematous pyelonephritis. So moving on to another patient, a diabetic patient. Patient is having a severe fever and ultrasound shown abscess in the upper pole. So it's a renal abscess. So sometimes, rarely, have appendix which is quite thickened here. You can see the appendix very much thickened, and you can see an appendicular lift also within the appendix, thickened appendix. So this is a very classical appearance of acute appendicitis. Usually the appendix patients, generally they present with pain and vomiting. Sometimes they also have fever. So this was a case of acute appendicitis. So another patient there where the appendix you can see is a thickened appendix. And this tip of the appendix is ruptured. Because of the rupture, and there is a collection here. So there's a rupture of appendix. So acute appendicitis with rupture is this patient with a fever. Another patient where there's a appendicular abscess. There's an irregular abscess in the right leg fossa. So this is a case of appendicular abscess. So here's a patient, female patient, where you have a right ovary. Surrounding the right ovary, there's a collection here. And in the pelvis, there's again a collection. You can see thick septas and thin septas and fluid with internal echoes. This was a pelvic abscess in a female patient. Again, this is a tubular structure. You can see a tubular structure here. This is the involutions, and this is a classical fallopian tube. The fallopian tube with internal echoes and with fever, we thought as a pyosalpinx. Sometimes this internal echoes can also, as in hematosalpinx, also can give this appearance. But when you have fever, this we thought as a pyosalpinx, and it turned out to be pyosalpinx. Sometimes you have a bladder calculi, which can, because of that, there'll be thickening of the bladder wall, and this is a vesical calculus with cystitis, which is another cause for fever. So bowel, actually examination of the bowel is another difficult area in ultrasound. But when you use a high frequency probe and use compression, sometimes you will be able to diagnose a case like this where there's a diverticulitis involving the sigmoid colon. So sigmoid colon diverticulitis with abscess here. Okay, diverticulitis with abscess, diverticular abscess. You can diagnose certain pathologies if you give focus and concentrate with a high frequency probe. So this is again a case where the bladder wall is thickened. As a case of cystitis, patient with cystitis. So most of the times the bladder has to be adequately distended. Sometimes when your bladder is partially full or it's empty, the bladder wall will appear as pseudo thickening. It is not a true thickening. So your bladder should be adequately distended. Then if you have the bladder wall thickening more than 3 millimeters, then you suspect a cystitis in these cases. So this is a post-operative case where there's mesh is kept there, and there's infection surrounding the mesh. There's an abscess surrounding the mesh, and a fistulous communication also has happened. A sinus tract from the abscess has also happened, and this was the cause of fever in this patient. So here is a case where the psoas abscess is there, and you can see lymph nodes, enlarged lymph nodes with psoas abscess. So this is cause of fever in this patient. So moving on from the abdomen to scrotum and other areas. So commonly you see in acute epidermolysis, sometimes the acute epidermolysis is not treated well, then this abscess formation happens in the epidermis. This is a testis which is appearing normal, and this is the abscess within the body of the epidermis. There is another case where there is the acute epidermitis. The epidermis is so thickened, and the scrotum testis has to be uniform like this, uniformly echogenic. But whereas here you see a lesion here, and this is the testicular abscess just happening. This is a scrotal wall. A large abscess was seen in the scrotal wall, and you can drain this with ultrasound guidance. And this is a case where there was a patient had a perianal fistula and perianal abscess. We use a transrectal probe and high frequency probe, and you can see an abscess. This is the anal canal. I can see a large perianal abscess. This is again a large perianal abscess. So again, it's very useful whenever you suspect perianal abscess. You can do use high frequency probe as well as transrectal probe, and you can identify the abscess, and you can also identify the internal and external opening of the fistula and anal tract. This patient had an abscess on the back, and this was a pylonal sinus abscess. You can see the abscess here. So this is a classical pylonal sinus with abscess. This is a case of post-injection. This is a post-injection abscess. You see a large abscess after injection in the gluteal fissure. So the take-home message here is not all fever you can localize the cause. So only in around 50 to 60% of the fever cases, ultrasound will be helpful in locating the cause of the fever. And common locations which has to be scanned in fever cases is the neck region, heart to look for any endocarditis or any vegetations, and chest always to look for peripheral consolidations and pleural effusions. And abdomen is one of the major source for the fever, and we often pick up a lot of things which clinically is not suspected. Many times clinicians are not suspecting where exactly it is, but abdomen shows a lot of findings which is cause of the fever. The scrotum again is another major cause for fever. And extremities, you can get abscess anywhere in extremities. Also sometimes you get can differentiate from in extremities like leg, like deep vein thrombosis, cellulitis with abscess. All those are possible to differentiate on ultrasound. And again, coming to the breast, again breast abscess from mass. The breast, another tool, ultrasound is very helpful. So thank you, sir.